I do want to make a good chunk of it because what we need to finish by the end of the day is the vessel lecture in order to keep track. But the way the respiratory lectures work, we're going to borrow a little time from there. And what I hope to do this time is to actually give you guys instructions on stuff to read ahead of time. It's just the anatomy of respiratory lecture. That anatomy portion really just covers the lungs, it covers the layers of the lungs. What we're going to hone in together as a class is specifically the functional unit, because that's where we're going to spend a good chunk of our time talking about. When we talk specifically about respiration, we'll talk about gas exchange, we'll talk about the volumes of gases and so forth. But I'm not going to go into that just yet. I'll save that for Thursday. So what we're going to do today is just, again, finish up that vessel lecture, at least make a good segue. And where we left off, we left off at the veins. Okay, so all we did, we talked about the structures of the veins. We're going to talk about the structures of the veins. We've talked about the structure of the veins, sorry. And let me just pull this up because this is going to give us a nice overview as well as some of the structural things I want to point out. It might be helpful if I can put this up here. All right. So we saw the artery. The artery delivers blood away from the heart. And in the systemic circuit, it's carrying oxygenated blood. In the pulmonary circuit, it's going to be carrying deoxygenated blood. So when we talk about the artery carrying oxygenated blood, please keep in mind that we are referring to the systemic circuit. What we're going to be looking at the artery specifically is the smooth muscle in the tunica media. On that outer layer is going to be a layer of smooth muscle, and that's going to play an important role on the resistance of the vessels. And what I mean specifically is going to be the biggest factor of resistance, which you'll see later at the end of today, is going to be the amount of vasodilation. How wide do we expand the vessel, and how much do we constrict? And there's a purpose for that. Now, when we look from the branch from the artery to the arterioles, and then from the arterioles into the medarterial, you'll see that we're going to have the capillary bed that we're feeding blood into. And so that capillary bed, we can regulate the amount of blood flow into that area. Why would we want to do that? Well, think about what happens when we autonomically regulate blood flow. With with sympathetic output, we want to increase blood flow in areas that are active tissues, mainly skeletal muscle, the brain, the heart. But we want to decrease areas that are less important, like the urinary system. We want to decrease blood flow to the digestive system and so forth. So we do have mechanisms that we'll be able to see in the artery to reduce blood flow to those areas. And then another thing that we'll be able to look at later my computer's freezing out. Well, I can draw it out from here. We're going to have precapillary sphincters that are not autonomically regulated that will reduce the amount of blood flow or increase the amount of blood flow to that area. And we'll talk about those factors in just a moment. I think it's time for a new computer. And then what we were supposed to see on that slide was the capillary bed. And you saw the increased cross-sectional area within the capillary bed. That basically means that blood flow, there's a lot of different paths for blood to flow in. And again, looking at that when we look at the cross-sectional area, yeah, it's definitely done. There we go, great. Let's see how long that lasts. And then when we look at the cross-sectional area, here you can see the diameter of the arteriole that's feeding blood into the capillary bed. And then when we look at the capillary bed, again, taking a nice cross-section of that area, you can add up the area of this area, and you can see that this is going to increase the cross-sectional area. And that makes sense, because in our capillary bed, we want to split up, and we want to be able to deliver blood to those capillaries to all of the cells in that particular tissue. And then they converge back, they make their way back into the venule, which drains back into the vein, and then vein returning back to the heart in all cases, in all circuits. And this is going to be carrying deoxygenated blood in the systemic circuit. So keep that in mind when we look at the cross-sectional area. We'll tie that into how blood flow is going to work in through the capillary bed. Now let's start to zip through and take a look at where we actually left off. We're starting at forces and pressure, and that's slide 22. Because now what we want to look at is the delivery of fluid. We're talking about fluid moving in and out of the vessel. And that's going to be one factor that we're going to be looking at, and how we're going to be able to deliver stuff to the cells. So here what we have the, let me just draw a cell on here. Here's our cell. And let's say that this is an active skeletal muscle tissue. So therefore, what we're going to see is we're going to see increased CO2 production within and decreased oxygen. And that's because this cell is undergoing cellular respiration, it's churning out ATP, and therefore we're going to need to get gases delivered by the capillaries surrounding. So we know, which we're going to look at the tail end of this lecture, or actually, I'm sorry, in our respiratory lecture, we know that oxygen is high in the capillaries, more specifically on the arterial side of the capillaries, and that's going to cause diffusion of O2 from the blood into the interstitial fluid. And then from the interstitial fluid into the cell. So that's going to be simple diffusion, and we'll talk about that in a little bit, and that's pretty self-explanatory. How do we get stuff across? When we look at glucose follows the same way. Glucose out in the blood, glucose in the interstitial fluid into the cell. Now what we're going to be specifically talking about is just the movement of fluid. And that fluid is going to be important too, because that's going to be also another contributing factor to how we're going to get O2, we're going to have glucose move across. So one way to kind of just use an analogy would be like a wave of fluid. You get fluid that moves out of the capillary, and that's going to carry the same nutrients, it's going to carry the same gases along with it. So this is one contributing factor. But in order for us to understand how fluid moves out of the capillary and then back into the capillary, we have to understand the pressures. And so this I'm going to draw on our old example of our U-tube example. So I'm going to take our tube, I'm going to use that selectively permeable membrane right in the middle, and I'm going to draw our solutes. And our solutes in this case are going to be stuff that's in the capillary. And then this will represent the capillary. I swear I'm spelling it right. There we go. Great. And this will represent the interstitial fluid. And naturally, we're going to have a lot more stuff in the capillary. Because remember, there's things that cannot cross through the capillary. We've got a bunch of blood cells in there. We've got red blood cells. We've got white blood cells. We've got proteins in there that can't necessarily cross through. And in the interstitial fluid, we'll have less things, more so like some gases. We'll have some sugars in there. And let me draw those extra dots I'm drawing on there. And as I mentioned before, the direction of, and if I were to even out the water levels in there, the direction of water flow, we want to move in the direction of a higher concentration of the solutes. Meaning, in the capillary, we're hypertonic compared to that of the interstitial fluid. And again, hypertonicity or tonicity refers to the amount of solutes in a given amount of fluid. Do you have a question?
Yes, sorry to interrupt. Do you have to connect to one of those
packet? No, I don't. No, I don't. I trashed those the day of lecture. Do you have a computer to pull up?
I didn't bring mine today, so I'll
Okay.
do it on
Okay. Now, the tonicity is, again, referring to the number of solutes in that fluid. And so what we understand by now is the balance of fluid. Which direction does water want to move? Now, water is the only thing that's really going to be moving through that selectively permeable membrane. And that permeable membrane is the endothelium of the capillary. That's what's going to separate the capillary from the interstitial fluid. And water wants to move in the direction in order to balance out the concentrations. So if I've only got 2 solutes over here and I've got 6 solutes over there, we're going to effectively bring down the volume on here, where water is going to move to the left in order to increase the volume to the right, eventually up to the point that we could manage the same concentration on both sides. So that movement of water, again, was one of our quiz questions. What is the movement of water? Osmosis, thank you. So that is the osmotic pressure. The osmotic pressure is the pressure moving that water molecule over to the left. So I'm going to draw a water molecule, a single water molecule over here. And osmotic pressure is what's driving that pressure over to the left. Now, looking at the other pressure, eventually we're going to get up to the point that our water volume is going to rise and rise and rise. But it's not going to completely rise all the way because we've got a static column of water mixed with a bunch of solutes, and that's going to exert another pressure on the opposite side. And so if you were to think of a bucket and I punctured a hole in the very bottom, we would see that the pressure, the water would want to push that water out. And that is what's going to oppose the opposite side. So hydrostatic pressure is pushing off to the right. And another way, again, of looking at the example here is if I take a balloon and I fill it up with water, eventually I can keep filling it up with water, but the pressure that's being exerted by that static column of water is going to push right back out. So that's hydrostatic pressure. Anytime you put fluid in a vessel of any kind, it's going to push back. So that is our hydrostatic pressure. And the hydrostatic pressure will oppose that of osmotic pressure. This is our hydrostatic pressure. Now, the direction of that water movement is going to be inherently dependent on the net pressures. Again, the pressures coming from the right for our hydrostatic pressure and our osmotic pressure pushing towards the left. So if I have more hydrostatic pressure, that's going to push that water molecule over to the right. And what does that mean? That means water is going to be pushed out of the capillary into the interstitial fluid if hydrostatic pressure is higher. Now, in contrast, if osmotic pressure is high, that's going to pull fluid, or if we've got more osmotic pressure than hydrostatic pressure, that's going to push it over to the left. And again, that means water is going to be moving into the capillary. Now that we have that in place, now that we've understand the forces that's being exerted on a water molecule, again, I'm looking only at one point, we want to look at the variance from the arterial side and the venous side of the capillary bed, where we're going to be seeing differences in pressures that's going to lend to pushing fluid out of the capillary and pulling fluid back into the capillary. Okay. What questions do we have about this prior slide? Yes?
So is the hydrostatic pressure, that's the pressure of like the solute or something?
It's the pressure of the fluid inside the vessel. If I were to take your vessels right now, and it's filled, well, obviously it's filled with blood, there's a pressure being exerted on each point of that vessel, and that's just the fluid filling it up. So that's the same thing that's happening over here. I've got a column of fluid or water that's putting pressure on the capillary wall. Okay? So as I start to fill this up, It starts to fill up, fill up, fill up. It's weighing down. It's wanting to exert a pressure back on the other side. Anytime you fill something up, in the case of the vessels, it's going to want to push back. So the pressure, the hydrostatic pressure is, if we were to think about that in terms of, and this will start to make a lot more sense towards the end of our lecture because we'll be talking specifically more about the pressures out of the heart. When you look at the pressure in a vessel, that's going to play a role on pushing fluid out. So let's take a look at the next slide, and hopefully that'll start to tie that in a little bit more. Now, looking at the capillary, when we look at the net pressures, and that, again, that's a balance of our hydrostatic pressure as well as our osmotic pressures. The balance of all of that throughout the capillary bed is all balanced out through what's called Starling forces. And that's a measurement of the forces, again, the osmotic pressures as well as our hydrostatic pressures, that will govern the direction at which the fluid moves, at which point the fluid moves out, and at which point the fluid moves back in. So this should start to make sense. The big picture behind this is if I get filtration, and we'll talk about these terms in just a little bit. If I have fluid moving out of the arterial side, that's going to allow us to deliver O2. It'll allow us to deliver glucose. It's going to push fluid out into the tissues. And then on the venous side, we're going to have fluid pulling back into the capillary. And that should make sense because now that helps wash out some of the things on the outside of the cell. Some of the metabolic byproducts. We might be seeing lactic acid being produced by that active cell. And therefore, we want that to diffuse back into the interstitial fluid, back into the blood. So we're seeing fluid exchange that's taking place. So what we need to understand what's taking place is we want to see the direction of blood flow, or rather, direction of flow. Blood flow through the blood, but the direction of fluid exchange that's occurring on the capillary bed. When we have higher pressures, exerting pressure, moving fluid out, that's what we call filtration. And the easiest way to kind of think about that is, again, we have the endothelial wall. If we want to get only fluid out and keep the red blood cells in, we're filtering water out. And what's actually coming out is something similar to blood plasma, things that are dissolvable in the plasma while keeping the red blood cells on the inside. The other side, where we have fluid entering the capillary due to more pressures pushing fluid into the capillary, is what we call reabsorption. And what we're doing is reabsorbing fluid back into the blood. So now that we have that established, let's take a look at our next slide. And our next slide should look blank because we're going to start to fill this out. And each of these I'll be pulling from the next 3 slides. So the interstitial fluid and our capillary represented by our tube here. You can see the red is more the arterial side. And this is our venous side. And the first thing that we're going to start off with is osmotic pressure. Remember, we've got a bunch of solutes in here. We've got our red blood cells, we've got proteins, we've got hormones in there, we've got albumin, we've got fibrinogen, we've got a bunch of proteins that the liver produces, stuff that's in there. So when we look at the direction of water movement, as I mentioned earlier, osmotic pressure is going to be from the interstitial fluid into the capillary. And that measure is about 26 millimeters of mercury. That's the pressure of osmotic pressure that's being exerted into the capillary at all times. Again, that's the drive for fluid to move into the capillary. The other thing that we also have to look at are the pressures. And let me see if I can go back to an early slide that just gives us, nope. The pressures in, okay, maybe it's a little ahead. Let's see. No, that's okay. The pressure on the arterial side is going to be 35 millimeters of mercury. While as that blood flows through the capillary bed, we're going to see a reduction in the pressure. And there's an earlier slide that I think I know where it is. I can't seem to find it right But the pressure is going to be 35. By the time it reaches the middle, it's going to be 25 millimeters of mercury. And by the time it makes it towards the end, it's going to be about 16 millimeters of mercury. And that's just showing that the pressure, the blood pressure, or in this case would be blood hydrostatic pressure, would drop from the capillary side all the way down to the venous side. The longer blood has to travel through a vessel, the more the pressure is going to drop. Okay? And if you were to, for instance, measure the blood pressures in the aorta, and then measure the blood pressures towards the end of the arm or down by the feet, you'll see that the longer that the blood has to travel, that pressure will decrease over distance. Yes?
Is there capillaries in the arteries?
I'm sorry?
Is there capillaries in the arteries?
Well, no, we're going from artery. Artery is going to be the big junction over here, and then this is going to break off into the arterial into the metarterial, and then this is specifically the capillary bed. So as we make, as you were, let's say you were that red blood cell making its way from outside of the heart, making your way down to the capillary bed, you'll see that the pressures will drop. Give me a second, let me see if I can find that. I'm getting there. I know I saw it. I know it's there. There we go. This is something I want to show you guys. Here you can see the pressure from the heart. Now if you were to measure the pressures right in the aorta, you can see the pressures are fluctuating quite a bit. And the pressures are, you'll see they'll fluctuate between 80 to about 120 millimeters of mercury, just like we talked about last week. And when we see the diastolic pressure and then the systolic pressures when during ventricular systole. So now as we make our way down, you'll see the pressures start to decrease, and that's just because we're moving further and further away from the heart. And overall, the pressures will decrease all the way up to the point that we get back to the vena cavas. So blood returning back to the heart through the inferior and superior vena cava, the pressure's low. And that's just a factor of distance. If you don't believe me, take a garden hose. Take one short garden hose, take one really long garden hose, and turn up the flow on each of the nozzles at the same rate. And if you were to take a look at the pressure at the end of the short hose, you'll see pressure's hot. It's spewing out water pretty quickly. But you take that all the way, that hose that's the longest hose, and you'll notice the pressure's really low. And that's just a factor of blood having to travel its distance. And if you were to take a look at the pressure at the capillaries, which is represented by the purple band, here you can see the pressure's about 36, 35, 36. And by the time it reaches the very end, it's about 15, 16. Again, so now here you can see the appreciable drop from the arterial side over to the capillaries, to the venous side. Did that help? Yeah. So now that we have established, again, 35 millimeters of mercury, 25 millimeters in the middle, and 16 right towards the end. There's one factor that we also need to look at, which is the interstitial fluid osmotic pressure. There's still stuff dissolved in the interstitial fluid, things like glucose. Let's just say glucose for now. There's also some lactic acid in there. There's some proteins in there as well. So there's also an osmotic pressure driving outward. And that is what we call our interstitial fluid osmotic pressure. And that pressure is usually about 1 millimeter of mercury. So you had an osmotic pressure where fluid wants to move into the cell due to the stuff that's dissolved in the blood. And there's also a drive for fluid to move out due to stuff dissolved in the interstitial fluid. But comparatively speaking, you can see the biggest drive for osmotic pressure is into the blood because we've got a lot more stuff dissolved in the blood. So all we need to do at this point is to measure the net pressures, just like I did earlier. If I have 10 millimeters of mercury pressure pushing that water molecule to the right, I have 10 millimeters of osmotic pressure pushing to the left, that net pressure is 0. And therefore the net movement of water is equal on both sides, meaning I've got one water molecule moving in, one water molecule moving out. So here all we need to do is just measure each of these three. So again, this is the arterial side, this is the middle, and this is the venous side. So measuring that all out, I got 35 plus 1. So this represents, right in the middle is our hydrostatic pressure. These on the outside represent the osmotic pressures. So measuring this out, 35 plus 1 is 36. And then the opposing direction would be the interstitial fluid. So the net pressures, in this case, comes out to 10 millimeters of mercury out. So therefore, if you look at the pressure on the fluid, that's going to push fluid out. And we call that filtration.
How did you put that again?
35 plus 1 minus 26. Is that right? Yeah. Now on the other side, I've got 25 millimeters of mercury, again hydrostatic pressure, that's the blood pressure in the capillary, plus 1, 26, minus the 26 of osmotic pressure pulling into the fluid. So 25 plus 1 minus 26,
Yes.
that comes out to 0. So the same amount of water molecules that make out will get pulled back in. So net movement is 0. And then on the venous side, 16 plus 1, 17, minus the 26 comes out to negative 9 millimeters of mercury. And that means there's more fluid going back into the blood than coming back out. And we call that reabsorption. So here you can see the differences in pressures on the arterial side versus the venous side. So what exactly are these numbers that I'm pulling out? If we look at, first starting off with the 26 millimeters of mercury, we call that the blood colloid osmotic pressure. And that's described for you on this slide over. Blood colloid osmotic pressure is due to the presence of blood plasma proteins. So therefore, the proteins that are present, hence the term blood colloid, stuff that's dissolved in the blood, you get the osmotic pressure wanting to go into the blood. The other pressure on the inside of the capillary that's being exerted out onto the capillary wall, we call blood hydrostatic pressure, BHP. And that's described for you on this slide. And that blood hydrostatic pressure is the pressures generated by the heart. It starts out from the aorta, which is going to be about 120 over 80. By the time it makes its way over to the capillaries, you'll see that it's going to vary from 35 over to 16 from the arterial to the venous end. And the last of these is the interstitial fluid osmotic pressure. And again, that's the drive of fluid wanting to move out due to the interstitial fluid proteins and stuff dissolved in the interstitial fluid. So again, a balance of all of these. The other one that we didn't quite mention is interstitial fluid hydrostatic pressure. And again, hydrostatic pressure would be the pressure in a vessel. And in this case, that would be the pressure in the interstitial fluid. And in normal cases, that interstitial fluid osmotic pressure, interstitial fluid hydrostatic pressure is basically 0. And that's because in a normal environment, we shouldn't have higher pressures in the hydrostatic, in the interstitial fluid. That should be fairly normalized. And that's really only a factor in edema. So looking at all of this, does this balance out? I've got 10 millimeters of mercury pushing fluid out, which we call filtration. I've got 9 millimeters of mercury pulling blood back in. Does that balance out to you guys?
No.
Almost, but not quite. So if you were to sum all this up, 10 plus negative 9, that means there's 1 millimeter of mercury pressure difference that is not accounted for in this diagram. That should mean overall, there's more fluid going out than there is fluid coming back in. And over time you would think, well, aren't you going to be losing fluid? And that's where the last slide comes in, the excess fluid drainage. any excess fluid that is secreted out of the capillary, and we do have about 85 to about 90%, and that should make sense. About 1 out of 10 millimeters of mercury of pressure is exerted, pushing fluid back out. So about 90% of the fluid makes its way back in. The other 10% will remain in the interstitial fluid. So we want to see that where it makes its way out, it's going to drain out into our lymphatic system. So we have lymphatic vessels that are present embedded within the interstitial fluid. And that allows for this drainage. And that drainage through that lymphatic fluid makes its way through. And if you were to measure the stuff that's in the lymphatic fluid, very similar to blood plasma, which should make sense. Because that's what's being filtered out in the first place. We get blood plasma in here that gets pushed out, then it makes its way in, and then it drains out through the lymphatic vessels to make its way back through the subclavian veins to drain back right into the vena cavas, returning back to the heart. So this should make sense, especially when you look at what happens in terms of surgeries. Anytime there's a surgery that comes in, let's say a mastectomy, where they remove breast tissue, they could affect any of the lymphatic vessels over there. And what happens with those cases? When you start to disrupt the lymphatic vessels flowing back in, you get edema. And so you'll start to see enlargement of the arms. You'll see the inability for extremities to drain fluid back, well, specifically the interstitial fluid. They can't drain that back into the main circulatory system. So if you're ever curious, look into cancer patients, and one of the things that they have them do is to wear compression garments, because they want to be able to exert some form of squeezing that's going on that will allow proper drainage. If you ever look at diabetic patients, and they wear compressive garments, they wear it around their ankles, they wear it around their legs. What they're trying to do in that case is return blood flow back to the heart by providing an excess, extra pressures to drain that back out. So let's kind of play this out. Now that we're looking at it, let me just draw our vessels once again. And let's take a look at what happens in the case of edema. So again, edema is characterized by excess fluid in or surrounding the blood capillaries and within the tissues. You've got excess fluid build up. So we're going to draw our pressures once again. Actually, let me even take a step back and let's take a look at hypertension, shall we? So hypertension, again, is high blood pressure. And we're going to take somebody who's at 120 over 80 and bring it up quite a bit. We're going to bring them up to about 150 over 100. And what that's going to translate out to is going to be a 10 millimeter mercury difference for hydrostatic pressures. If I increase blood pressure, I'm going to increase hydrostatic pressure. So in this case, we're going to have 45 millimeters of mercury, 35, and then 26. The same factors come into play. We get 1 for IFOP, which is going to be 1 millimeter of mercury. We're also going to get 26 millimeters of mercury for our blood colloid osmotic pressures. And then we just measure that out. 46 plus 1 is 46, minus 26, 20 millimeters of mercury. For filtration, we'll take a look at this one, 35 plus 1, 36 minus 26, 10. And at the very end, 26 plus 1 minus 26 is 1 millimeter of mercury. Yes?
So how come you're subtracting the 26 though?
Because the pressure is pushing out. Hydrostatic pressure pushes out, right? Blood colloid osmotic pressure pulls right back in. Hydrostatic pressure out, osmotic pressure going back in. And that osmotic pressure is blood colloid osmotic pressure. That's a direction of water moving into a hypertonic solution through the presence of solutes. So these are opposing pressures. The only other one that is not opposing for the osmotic pressures is the direction of fluid wanting to move from the blood into the interstitial fluid. Do the stuff dissolved in the interstitial fluid? Does that help?
Yeah.
So by looking at that 45 plus 1, and then the opposing blood colloid osmotic pressure is 26. Any other questions before we move on? Okay. Now looking at those pressures, now that we're able to determine the opposing pressures, we see, well, let me ask you guys. Do you see at any point in this example where reabsorption is taking place?
Yes.
Where do you see reabsorption taking place?
Nowhere.
With the 1
Nowhere.
millimeter.
This is 20 millimeters out. This is 10 millimeters out. 26 plus 1 minus 26, this is 1 millimeter mercury out.
The 1.
This is still out. 26 plus 1,
Oh, it's
and then minus 26.
So you have to have a negative for it to be reabsorbed.
Exactly. So there's no net pressures pushing back in. Now think about what happens in, let's say, the case, and I'm just going to draw a very basic leg here. There's my foot. And again, for simplicity's sake, let me just draw one capillary going through. That means more fluid is being exerted to the outside. So more filtration is going to now cause more fluid buildup in the interstitial fluid. The lymphatic vessels can't drain it fast enough, so what you're going to get is going to get edema. And that's going to be a buildup of fluid, which not only that, what that's going to do, it's going to now increase interstitial fluid hydrostatic pressure. Now the interstitial fluid surrounding is now going to exert a good amount of pressure, because now you've got all this fluid in there. You're going to get more pressures that's going to come back in, which might help balance it out. But nonetheless, any way you look at it, you're going to have more fluid buildup. And it's not uncommon for people with hypertension to have edema, swelling of the legs. And again, these are kind of more kind of extreme examples. And I know we have corrective measures in this case, but I'm just pointing out that this is worst case scenario, at least a worsening case scenario. So take a look at each of these. You'll see the pressures in play. Filtration, these are the pressures being exerted out. So these are all outward pressures. These refer to inward pressures. And when you sum all that up, again, 90% of fluid moving out of the capillary, the other 10%, 85 to 90% being reabsorbed through the lymphatic vessels to make its way back into, returning back to the heart. And that's fluid exchange. What questions do we have about fluid exchange? Now moving over to the next slide. We've talked about, again, the movement of fluid, and now what we need to talk about is the movement of everything else. And what I've been able to describe for you is bulk flow. We have two other ways of getting things in and out. We've got diffusion and transcytosis, which I'll describe in a bit. Everything else that we've described is bulk flow, the movement of dissolved and suspended materials with fluid through filtration and reabsorption. Again, that tidal wave of stuff. Water moving throughout, which is being filtered out of the capillary, and we're going to have stuff that's also dissolved with it. So O2, CO2, well actually rather O2, CO2 being reabsorbed. We'll have glucose as well. Everything else is going to either use diffusion or transcytosis, but the biggest one of them all is diffusion. And diffusion we've talked about. This isn't new. This is looking at our concentration gradient. Again, as I described earlier in our earlier slide, O2 just diffuses across out of the capillary bed into the interstitial fluid because I've got a higher concentration gradient on the inside of the capillary, and then it's going to move in the directions of where there's a lower concentration. Same thing with our glucose, same with everything else, with the exception of the things that are dissolved in blood that can't pass through the endothelium. Now, transcytosis is the other concept, and basically this involves the movement of stuff in between cells. So if I were to take a look at the capillary and really zoom into the capillary is going to have simple squamous cells, epithelial cells, very thin layer. And the other way, if they're not moving through in between the epithelial cells, they're moving through it. So in this case, the only way to get things to move out would be to undergo endo or exocytosis. Endocytosis to make its way into the cell, exocytosis to be ejected out of the cell itself. And when you look at lipid-soluble hormones, let me cross out insulin because insulin is actually a water-soluble hormone. Lipid-soluble hormones can diffuse across into the cell, and then they can make their way out the cell as well. And then looking at water-soluble hormones can make their way up through blood flow. And that should make sense because as fluid moves through, filtered out of the capillaries, things that are dissolved in the blood should also make its way out. So those are the three main ways. Again, diffusion, which is down its concentration gradient, transcytosis through the cell, and bulk flow, utilizing the pressures that we discussed in our prior slides to push fluid out and return that back through the venous side. And all of that is summed up for you on the next slide over. Something you might not be able to read from here, but when you look at it, it's pretty much describing everything that we've been able to describe earlier. So utilize this. This talks about the differences in outside variations that occur. And I can draw that one out for you. It's basically the first example that talks about the variations that could occur outside of normal capillary function. Let's take a look at what happens when blood pressures decrease. I'm going to draw in contrast.
You don't give me the right.
No, I'm just looking for a different color. Let's take the case of hemorrhaging, blood loss, or low blood pressure. So when we see low blood pressure, we're going to see hydrostatic pressure decrease. So take somebody with abnormally low blood pressure, let's say like 80 over 30 or something like that. And what that's going to come out to is 25 millimeters of mercury. This is again 10 millimeters of mercury less in hydrostatic pressure for that of somebody who is hypotensive or has undergone hemorrhaging. So 25 millimeters of mercury, 15 millimeters of mercury, and then 6 millimeters of mercury. Again, same things, 26 for our blood colloid osmotic pressure. Interstitial fluid osmotic pressure is going to be 1 millimeter of mercury. Measure that all out, 25 plus 1, 26, minus the 26 for the blood colloid osmotic pressure, 0 millimeters of mercury is the net pressure. This one, 15 plus 1, comes out to negative 10 millimeters of mercury. And then 6 plus 1 minus 26, negative 20 millimeters of mercury. So looking at these numbers, do I have more pressure going into the capillary or more pressure going out of the capillary? Into. So somebody who has lost blood, we have a system in place to recall more fluids from the interstitial fluid back into the capillary. So take a look at somebody who is undergoing trauma and they've lost a good amount of blood. You would see their skin looks pale and very thin. That's what we call recall of fluids. These are things where more fluid is going back. We're draining fluid back into the capillary to maintain blood pressures. And that's only happening on the tissue level. We haven't even looked at what happens at the heart level, which we'll explore at the end of this lecture, which we call when we talk about shock. Any questions so far? Yeah, transcytosis, exactly. Transcytosis is the movement of stuff through the cell. If diffusion is stuff moving just out down its concentration gradient, whether it moves in between the cells, Diffusion is just through the cell. And basically all you have, if you were to take large molecules, they have to be able to pass through the cell membrane and pass out the cell membrane again. Okay? Does that help? All right, so now looking at, any other questions? So looking at, now we're going to take a step back and look at where all the blood is stored. And this pie chart, as we looked at in the very beginning of this lecture, we saw that where most of the blood is specifically in the systemic veins and venules. 64% of your blood is stored in the veins. And I know I was kind of touching on what happens with hemorrhaging, the loss of blood. We have a venous reserve. And if you ever look at it, take a look at somebody who has fairly thin skin and look at them at rest when they're just sitting there. And I guess, I don't know if you want to look at your neighbors or anything like that and look at their veins, or I guess don't be creepy and don't look at their veins. Somebody who's at rest, you'll see that their veins are fairly prominent. And that should make sense because most of the blood is stored in the veins. Now get somebody who is starting to become active and they're starting to exercise a little bit, and if you were to look at their veins, what happens is that their veins start to deflate a little bit. Okay? And that's because that blood is returning back to the heart. So what we're looking at in this slide is our venous reserve. What we're doing is redirecting blood back into the heart. So we know that the veins return back to the heart. So if I can just draw our heart, here's our arteries, and here are our veins. And in order to raise blood pressure back up, let's take the case of hemorrhaging. You get a decreased blood pressure. Maybe hemorrhaging is a little too extreme, but your blood pressure decreases a little bit. What we want to be able to do is tap into our veins to bring blood pressure back up. Because one thing we're going to learn is that when we see a decrease in blood pressure, there's a decrease in blood flow, which I'll explain later. Now, in order to get blood back to the heart, we can utilize what's called venoconstriction. Because to a certain degree, we do have smooth muscles that wrap around the veins. And if I can help squeeze blood back to the heart in the systemic circuit, I'm getting our veins to return blood back to the heart. That should make more sense because now I've got more blood returning back to the heart. That means that the heart can now stretch out a little bit more and therefore can contract more blood. This concept we discussed is the preload. Again, another one of Frank Starling's concepts of force. The more you stretch out the heart, the more blood that's being pushed out. So now let's take that back. With a drop in blood pressure, we want to employ venoconstriction to squeeze more blood back to the heart, which can stretch back out and then squeeze more blood out to now raise blood pressure. More fluid or more blood that's pumped out of the heart will effectively raise that back up. So this is how we're able to increase, at least one mechanism of increasing cardiac output is to bring more blood back to the heart. And if we're to take a look at the next slide, the next slide sums up all of the effects of sympathetic and parasympathetic. Sympathetic to the right, parasympathetic to the middle, and the left describes all the different areas that we've looked at. So now this should complete everything we've looked at so far. SA node versus AV node. Again, these are the pacemaker cells. Ventricular muscle and atrial muscle are muscle cells. These are our muscle cells. These are our pacemaker cells. Right. And then we knew with the SA node, with the sympathetic output, we know that's going to increase the rate of depolarization of our pacemaker cells, namely our SA node and AV node. We knew that the sympathetic effect is most prominent on the muscle cells, causing increased contractility. So now I'm only going to take my heart, I'm going to take the arteries and veins that did the same thing I described earlier. The sympathetic output is not only going to raise the heart rate, it's also going to cause an increase in the stroke volume. So as we described at the tail end of Thursday, we see an increased contraction due to increased calcium uptake by the cells. Increased calcium uptake then strengthens the contraction, causing that muscle to squeeze even stronger. The stronger the squeeze per beat, the higher the stroke volume. So now an increase in heart rate and an increase in stroke volume effectively increase cardiac output, which should make sense. That's what we're trying to do with sympathetic stimulation, increase cardiac output. Now the last thing on here, well, the second to last thing is just the adrenal medulla, and this is just showing the effect of increased epinephrine. And epinephrine is there just to supplement the sympathetic output from the central nervous system. Now the veins are going to increase venous return. So sympathetic stimulation is going to increase venous return through venoconstriction. Again, effectively raising the amount or increasing the amount of blood return back to the heart, employing the preload effect. Any questions on that? So now that we're talking about venous return, we saw venoconstriction. Let's take a look at other ways we can return blood back to the heart. Because now we're going to just take a little bit of a step back and look at how blood, and to use my example of the foot from earlier, my foot is getting worse and worse as I describe, as I draw it out. When we look at blood flow, I showed you the other slide earlier where we look at the pressures of the blood. Now the pressures of the blood are from 16 all the way up to about 5 millimeters of mercury. And when we looked at the heart, we saw the direction of blood flow is from a higher pressure to a lower pressure. So now if I take that foot that I drew earlier, and I have venous blood making its way back up the veins, not only do you have low pressures, you got from 5 millimeters, well I guess in this case maybe 16 millimeters of mercury, all the way back up towards the inferior vena cava where it's about 5 millimeters of mercury, you have very low pressures returning blood back to the heart. So the question is, how do we counter gravity, right? How do we counter gravity? How do we get blood flow to make its way through the veins to return back to the heart to contribute to that preload? So here, let's take a look at the structures of the veins. And again, drawing on what we talked about last Thursday, is to look at the valves that are located within the veins themselves. Again, extensions of the tunica interna. These epithelial flaps provide unidirectional blood flow. And that unidirectional blood flow we'll be able to see in just a little bit. I want to just do that as a precursor. The next is the skeletal muscle pump, as well as the action of breathing. So let's take a look at the next couple slides. Here you can see the presence of the valves right here, what they look like. Very similar to what you saw in the valves in the heart itself. So the two main mechanisms of venous return is the skeletal muscle pump. If you were to take a look at the valves, and again, these would be more the deeper veins. If you look at the veins, you can see the veins allow blood flow in one direction. But the principle of it is that when blood flows back into, blood flows up in, let me just draw a different color here. Blood flows up and then circulates back around. And the increased pressure in this segment causes this flap to close, preventing blood from leaking back down. So what assists that squeezing of that blood in that segment is the skeletal muscle pump. And you can see that the adjacent muscles surrounding. Here we have the tibialis anterior, we have the gastrocnemius and the serratus. And anytime you walk around is going to help squeeze those different segments. So I can draw our muscle here in green. Squeeze that blood back, employ any sort of minor squeezing, and you don't need much. You just have to have the muscle contraction that takes place and squeezes those vein segments that allows fluid to move up that chamber. This whole process is what's called milking that blood in that direction. All you're really doing is just squeezing in that area, pushing blood up to the next segment, and so forth. This is one of the reasons that, does anybody know any like hairdressers or any people that have jobs where they stand all day? One of the things, have you guys heard of what they can do to help in venous return?
Stop lagging.
Like the
Compression.
compression, yeah, that's a way of doing it. That helps with the subcutaneous veins, because we do have subcutaneous veins on the outside. Another way that they can employ is to literally just move around. Utilize the skeletal muscle pump. You'll watch people and I do it myself, I move around quite a bit. By doing that, anytime you're just causing contraction, it's gonna help with venous return. Otherwise, if you just stand in one place all the time, you're not employing that venous return. Blood stays in that segment, and it pools, and it causes dilation of those veins. And the dilation of the veins will now pull those flaps further away, and that's where you start to see varicose veins.
Is that what also happens like when you're on a really long flight, when you fly by?
You're thinking of deep vein thrombosis.
Oh, okay.
Which basically is same concept, except blood pools over there and starts to clot.
Okay.
That formation of the clot, that's an extreme version of it. But that clot formation can come back, and once it breaks right back off, can make its way back and clot anywhere. So,
Does that also happen when your leg gets numb and you don't move it?
not necessarily. That's a good question. When you're, I never even thought about that. When your leg is numb, let's say you've kind of cut the circulation off a little bit. I actually don't even know the physiology behind that. I'll look that up. So all that is just the general principle of how we get blood flowing back in, and again, utilizing the skeletal muscle pump as well as the valves. The last is the respiratory pump. And the respiratory pump is going to utilize the thoracic cavity and the abdominal cavity. So I'm just going to draw our thoracic cavity, or rather our, and I'm going to split that up with the diaphragm, which is going to split the thoracic cavity and the abdominal cavity. And just a simple action of breathing is going to help assist in blood return. And thinking about what happens when, and again, something we'll be able to describe more in detail on Thursday, or maybe even more so on next Tuesday, is during inhalation, the diaphragm will contract and move down. So during inhalation, that's going to increase abdominal pressure and decrease thoracic pressure. Again, blood wants to move in the direction from high pressure to low pressure. So that's going to help move blood flow up. During exhalation, the diaphragm is going to relax. And that's going to increase thoracic pressure and decrease abdominal pressure. So as you have your veins, the movement of blood is always going to move from a direction of higher pressure down to lower pressure. And then the simple movement of the diaphragm is going to cause differences in pressure changes that allow, again, this milking effect to take place to return blood back to the heart. And yeah, that's really it. What questions do we have about the pressures? Because the next slide is going to talk about, has anybody ever seen anybody do any jet fighter pilot training of any kind? Or even astronaut training? What they do is our pilots would subject themselves to high G-forces. Basically, the pressures that are exerted that would pull blood away from their head. And what happens in those cases? They're subjected to these high pressures. Imagine somebody who's on a jet and they're going to curve upwards. And the force of gravity is so strong that it could pull blood from their head. It's not pulling all the blood, but you're going to see the blood pressure loss in the head due to blood wanting to pull back down. So this is an increased gravitational force that's pulling their blood towards their legs. So one of the things that they have to do and pilot training is to employ the same things that we've learned about, is to maintain or increase venous return. So one of the things I'll instruct them to do is to clench all their extremities. And that's employing the skeletal muscle pump to occlude blood from flowing down to the extremities. So employ the skeletal muscle pump, block the veins, and that's going to keep blood flow in the thorax. And then lastly, they're going to do what's called the Valsalva maneuver. And the Valsalva maneuver, if you haven't heard that before, is what we do to, simply put, it's what you're doing when you're doing a number 2. You're trying to force something out. You're clenching your abdomen. You kind of take a breath and you kind of hold your breath for a second. And by doing that, you're going to increase abdominal pressure and you're going to block the inferior vena cava. So by doing that, you're effectively keeping all the blood in this area to prevent blood draining. So what that does is actually going to raise blood pressure, but now blood is going to be pulling it back down. It's going to bring blood pressure back down. So this pilot training, what they're doing in this case is to employ that, again, skeletal muscle pump as well as the Valsalva maneuver to prevent the loss of consciousness that occurs during high G-forces. And you can see what's going to happen. You can see stages of gray out, tunnel vision, blackout, and G-lock, which is called G-force induced loss of consciousness. Let me play you the slides of somebody who's practicing. So they put them in these chambers. Should be. Don't mute. Volume. No, okay, that's not it. Okay, because volume isn't working. So here you can see the guy's face. You can see the draining that's taking place, and there he passes out. And then you'll see the G-forces right back up. They'll bring it right back up. Blood return comes back up. He comes back in. This guy's a little scary because he's spazzing out a little bit, but then he comes back too, and he's like, what happened? Where am I? Happens if you pass out, especially with the amount of blood flow that, the decreased amount of blood flow, cerebral blood flow.
Can we watch it again?
Want to watch it again? Sure. I don't know why we don't have volume here. This isn't working. It's always worked before. So here you can see the G-forces, 1.5, normal, almost a little bit above normal G-force. They do that to acclimate them. G of 1 is normal gravitational force. Watch them raise it. It's going to go up to about 10, 8, 10 when they first test it. Tell them to clench, hold on to the joystick, and there they raise it. Watch him, he's squeezing. They bring it up to 8. You can see the amount of gravity that's pulling on his eyelids, and he's out. And this is important. They have to learn how to do this because they're flying multi-million-dollar jets. Maybe it's not even million, maybe it's billions. I don't know. It's millions.
And also their lives are at stake.
Yeah, lives at stake, of course, and of course, casualties. Most importantly, their lives. That's right.
There's a video of a pilot who loses consciousness and regains it, and it controls the same jet that he was on.
Wow. I'm pretty
So
sure
they're
they're
trained for that, though.
Yeah. I'm pretty sure there's systems in place to prevent this.
Yeah, sure it goes with autopilot. and
Yeah.
so forth.
So he's out cold and he comes right back in. If they were to sustain that for quite some time, which obviously they wouldn't, that decreased amount of blood flow to the brain can cause ischemia and cause
It'll
some.
happen in less than a minute, right?
What's that? Doesn't take very long. And this one you can't really see, but he basically passes out, and it's, I don't know how many minutes of it. And just for the interest of time, you guys got the idea, right?
Yeah.
So what happens with the different stages? Gray out, tunnel vision, blackout, and G-lock. So you'll see that the differences in the stage of this, it's not like the first thing that happens is you pass out. If you were to ask them to report what symptoms they're seeing, they call it gray out. Gray out is the loss of color vision, and that's due to the decreased blood flow that's happening in the retina. We know that the cones, which see color, typically will fire more, and of course require more blood flow to the retina for that. So the first thing we lose is color vision. The next, what we lose is tunnel vision. So we see the loss of our peripheral vision, and our only focus is of that of the macula lutea. That's our central vision. So everything starts to close up, and they can only see centrally. The last thing will be blackout, where there's a complete loss of vision. They can still hear everything, they're still conscious, but they just can't see. And the last is vision. G-law. So last is loss of consciousness. Why is it our vision that goes out first? Well, we do have intraocular pressures, the pressure of the eye itself. And the loss of fluid to that reduces any sensory function within the eye. Looking at venous return, and just covering that, I think we'll get to, okay, cool. Right on time. So I'm going to go about another 15 minutes, if that's okay with you guys, 15, 20-ish? Sure. Yeah? Okay. All right. So looking at the venous return. So we've been able to describe what techniques we employ in order to return blood back to the heart. You'll see the pressures, starting from the aorta all the way to the vena cava. Our image to the left is going to show us the pressures. And you see the pressure fluctuating again with systolic versus diastolic, making our way all the way out to the arterioles. Then it smooths out. We see the loss of the differences between systolic and diastolic pressure as we make our way from the capillaries out to the veins. And again, to take a look at that pressure, what that purple line represents is our mean arterial pressure. And mean arterial pressure, again, is the systolic minus diastolic, divide that by 3, plus a diastolic pressure. So for somebody who has, I guess in this case would be about 105 minus 70, 30 about 10, 10, 110 minus 70, 40, divided by 3, 13.3, 13.3 plus the diastolic of about 70, that should make sense. That's our mean arterial pressure. That differences in systolic versus diastolic, again, lost by the time you get to our capillaries. And then you'll see an effective decrease in the hydrostatic pressure as we go from the arterial side down to the capillaries, just like we described in our earlier slides, and back down to our veins. Now, why do we see a decrease in the capillaries? We should start to take a look at the velocity. So looking at the blue, if you can focus your attention on the blue regions, everything from the venous side of the capillary to the vena cavas, you can see there's an appreciable decrease that continues all the way up to the point where we enter back into the heart after the vena cavas. If you're to take a look at the cross-sectional, or rather the velocity, so if we see the pressure, let's take a look at the velocity. The velocity of the blood, again, these are systolic waves where you get high pressures, lower pressures, higher pressures, lower pressures. We get down to the capillary, and then we see the velocity starting to increase despite pressure starting to decrease. So what we're going to start moving into is tying in pressure versus the velocity or the flow of the blood, and then also tying into the cross-sectional area. So here we can see, as we mentioned earlier, for the capillaries, we would see the cross-sectional area starting to increase for the capillaries. That gives us more pathways for blood to flow through the capillary bed. And then once it drains back out, let me just draw that out for you. And then that converges back into the venual side. The cross-sectional area decreases back by the time we reach back towards the veins. And as we start to converge back, now you see all that blood that's flowing through these 3 different pathways. Now they're going to converge back. We would expect velocity to come back up. But keep in mind, the distance that we're moving down the length of the vessel, pressure decreases, but the velocity starts to increase back right when we get to Well, the velocity decreases when we get to the capillary bed, which we can see here, and then the velocity starts to increase once we get back to the venule side. So we start to see a decrease in the cross-sectional area, and then an increase in the velocity. And another way to think about that, again, as I talked about on Thursday, is to think about what happens in a stream. When water's flowing through, and then you get this whole like lake area where water can flow through, water flow through that lake is very slow until it converges back through that area where it flows right back through. So let's take a look at the next slide, which was going to help tie us in pressure, flow, and resistance. And looking at each of these terms, blood pressure is that hydrostatic pressure, and that's the force that's being exerted on the vessels. Blood flow is just like cardiac output. It's how much fluid is moving through that vessel. And then resistance are all the different factors that oppose the flow. And I'll talk about these in just a little bit. So first I want to start off by looking at our tube right here. Or rather, I'm just going to have a bucket filled up with water. I've got a big bucket on my desk, and on there, I want to take a look at what would drain that bucket faster. If I were to puncture a small hole versus puncturing a bigger hole, which of those do you think is going to cause water to flow out the fastest? The bigger hole, right? So you'll see that the radius of that hole is going to make a difference. Another thing that will tie in is the length of the vessel itself. As I mentioned earlier, take a short garden hose, take a very long garden hose. The longer the hose, the reduced flow that takes place. And if I were to just draw out a really long vessel, over time that pressure is going to decrease because of the size of the vessel. The vessel wall will start to decrease over time, and that will effectively slow it down by the time you reach the very end. Another thing to look at would be the thickness of the fluid. If I've got fluid in here, like just normal water, that'll drain out fairly fast. But if I fill this up with oil, that's going to take longer for that stuff to drain out. So the viscosity is another factor as well. So looking at this pathway, I mentioned earlier, I have that huge bucket, and in that bucket, I've got a smaller hole versus a bigger hole. I want to point out that resistance, the bigger thing of all the different factors that come into play. The biggest factor is going to be the radius of the vessel. And again, the radius would be, if I were to take the size of the hole, it would be from the middle to the length. The radius of the vessel is going to be the biggest factor. So let's take a look at the size of the bigger hole versus the little hole, where the bigger hole has a radius of 2 and the smaller hole has a radius of 1. The resistance is proportional to 1 over the radius to the 4th power. That means that if I were to take that first vessel, let me take the first vessel. The first vessel has a radius of 4, or I'm sorry, a radius of 1. 1 over 1 to the 4th gives us a resistance of 1. And what do I mean by resistance? Let me give you another example. Resistance would be like the size of the tube itself. If I were to take like a small coffee straw versus taking one of like those bigger boba straws. If you were to blow into a smaller straw, there's a good amount of resistance in there just due to the narrowness of the vessel. Versus taking one of those bigger boba straws you can blow into, and you can get more air out through it because it's naturally bigger. So that represents the resistance, how much effort you have to be able to blow out through that hose, or not the hose, I'm sorry, the straw. So the resistance in this case is 1, where if I take something that is double the radius, that's 1 to 2 to the 4th power, that'll be 2 times 2 times 2 times 2, that comes out to 1/16. That means that the bigger vessel is 16 times less than that of the smaller, just by having the size of the radius. Or conversely, the resistance increases 16 times when you halve the radius. So looking at that, I'll show you the other equation for that in just a bit. Looking at all of this, we can see that the pressures are all related to blood flow. And we're more interested really on the amount of flow that's tied into the amount of resistance. And all these factors come into play. So when we look at the blood pressures, it's easiest for us to determine the amount of blood, well, it's easier for us to read blood pressures than it is to read blood flow. So if I want to take a look at your heart and say, what's the best way to be able to measure your cardiac function? Is to measure your blood pressure, and that should be a good indication of the flow. When I increase the pressure of something, the flow should increase, and that should make sense. If I increase the pressure, that should be able to be effectively push blood through that vessel.
But why is it when pressure, is it velocity or the other one? That it's directly in proportional?
This one was resistance.
No, the other one, velocity and,
We were looking at this slider here?
yeah.
Yeah, so what we're looking at is the decrease in pressure and then velocity. This is going to tie
Yeah.
into a later slide.
Okay.
So hold on to that one. Yeah, on this slide. So we can measure blood pressure because it's related to blood flow. And then when we tie in resistance, which we already know resistance is tied in again to the radius of the vessel, we want to take a look at the relationship between all of these. And this is going to follow something very similar, which was called Ohm's law. Ohm's law is something from physics. It's basically blood pressure equals flow times resistance. And while I'm not going to have you guys calculate these things, I will just kind of give you the general idea behind this. If the resistance is the same, let's say that the diameters of the vessels are normal. If I take a look at increased blood pressure, that should mean there's an increase in blood flow. And then lastly, if flow is the same, let's say the flow flowing out of the heart is the same, any increases in blood pressure means there's an increase in resistance. So let's take a look at the next slide, which is going to look at ways we can increase blood flow. And that, when you think about the sympathetic output, we want to increase blood flow to the muscles. We can do one of two ways to increase flow. I can increase blood pressure while keeping the resistance the same, or if the blood pressure is the same, I can increase flow by increasing resistance. Increasing flow by decreasing resistance. So if I were to take that example from earlier and just again draw a very simple chart. This is, we want to increase sympathetic output, and I want to decrease blood flow to the stomach and increase flow to the muscles. Right? So this would be the aorta. Again, very simplified diagram. I want to be able to redirect blood flow to which area? Do I want to bring it to the muscles or do I want to bring it to the stomach? I want to bring more blood flow to the muscles. I can't really increase pressure. If the aortic pressure is 120 over 80, I can't really make it like 200 over 100 over here and bring blood pressure back down in the stomach. That's not how it works. The thing is that's going to make the biggest impact is decreasing the vascular resistance. And vascular resistance, we can, again, looking at that resistance, the biggest factor for resistance is going to be the diameter of the radius of the vessel. The other factors of resistance are the amount of red blood cells. So somebody who has more red blood cells in their blood would make their blood more viscous. That was my example of blood doping that I used earlier, where athletes would inject more of their red blood cells back into their blood, which should increase the oxygen carrying capacity, but it makes their blood thicker. And again, your heart has to work hard to be able to pump that thicker blood. The other thing on there is increased total blood vessel length. The longer the vessel, the harder your heart has to work to be able to push blood down that length of the vessel. Why is this important? Obesity is another factor. When you think about increased fat deposition, when you see somebody storing more fat, why does that play a harder role on the heart? Well, when you think about that fat deposition, fat is a tissue. And in order to keep tissue alive, we have to create vessels around it. And those vessels would be capillaries that feed that fat. So, in that case, anytime you have fat deposition, every kilogram of fat that you store, you actually create 400 miles more of capillary beds into that area. So that means that's more blood that has to be delivered to those areas, which will effectively raise resistance because now your blood has to travel further. The biggest factor for affecting resistance is the blood vessel radius, like I mentioned earlier. In fact, if we were to take a look at the equation, and no, I'm not going to have you guys memorize this equation, but the resistance is tied into, if I can remember the equation, pi r to the 4th, and 8 times mu times length of the vessel, great. So resistance is equal to a factor of 8 times mu, where mu is the viscosity of the blood, L is the length of the vessels, and R is the radius of the vessel. Viscosity of the blood is going to pretty much stay the same. The length of the vessels is going to almost pretty much stay the same. These things aren't really things that we can adjust very quickly in order to redirect blood flow to the muscles. I can't make the viscosity higher for the blood that's going over the muscles. I can't increase the length of blood flow for the stomach. But what I can adjust immediately is the radius of the vessel. So therefore, what I would want to do for the stomach is to decrease the radius of the arteries leading to the gastrointestinal system. So by decreasing the radius by half means I'm decreasing the amount of flow by 16. I'm increasing resistance that would prevent or decrease the amount of blood flow to that area. While at the same time, I would want to increase the radius of the muscles, or I'm sorry, increase the radius of the arteries leading to the muscles. So again, the biggest factor for all of this would be the radius. And we employ that through, again, through what we call vasoconstriction or vasodilation. Vasodilation would lead to decrease in resistance, and vasoconstriction would result in increased resistance. Not to confuse this for venoconstriction, which was related to the veins, this is related to the arteries. So therefore, in that last slide, I want vasodilation for the muscles to increase blood flow to the muscles. I want vasoconstriction to decrease blood flow to the gastrointestinal tract. And we can do that all through the sympathetic output that targets the vessels in that area. So looking at this, when we see the converse of this, what happens with parasympathetic output? Parasympathetic output, we want vasoconstriction of the arteries leading to the muscles, and we want vasodilation of the areas leading to the stomach. So this vasodilation and vasoconstriction, we're constantly adjusting the radius of the vessels. And because we adjust it so much, the arteries actually need to be very elastic. So when you look at the, and something that they look in cardiology, is to look at arterial stiffness, which is a major factor. We want the vessels to be able to expand and constrict. that allows the changing of the radius of the vessels to allow more blood flow or less blood flow. And you'll hear the term arterial stiffening. You'll hear arterial compliance. These are all factors at looking at ways we can make sure that your arterial health is good. And other factors that come into play, arteriosclerosis. So if you take your arteries and then you get that plaque formation on the outside, what's going to happen with the vessel wall? It's going to start to stiffen. So you get fibrosis that occurs on the arteries. And now that you've got a narrowed radius here, you've got decreased surface area that blood can flow through, you get decreased blood flow through that area. And then not only that, you can't increase or decrease the radius of it because it becomes stiffened. So this is where they play a major role in looking at fatty deposits in your arteries. Why they want to make sure that your arteries will work the way they're supposed to in order to accommodate to increase and decrease blood flow.
Is that the cause of stroke?
Well, the cause of stroke is the breaking of that fatty deposits. Because over time, as your arteries are opening and closing, vasodilating and vasoconstricting, that could potentially loosen up that fatty deposit, and then it breaks off. And once that breaks off and makes its way through the circulatory system, that could end up lodging somewhere in the brain, causing decreased cerebral blood flow to that area, causing ischemia of that particular brain tissue. And that could be irreversible if not caught at an early time. So now that I've described all of vasodilation and vasoconstriction, what I've started leading into is autonomic regulations. These are the different systems that we have in play, and I'll just talk a little bit about it, about how we can adjust the pressure as well as the flow through those different areas that we talked about, whether we're moving from the muscles down to the stomach. How do we do that? We have the autonomic nervous system. We'll take a look at baroreceptor reflexes, chemoreceptor reflexes. We'll take a look at some of the endocrine pathways with the production of our catecholamines, and then vascular autoregulation. How do we maintain normal blood flow at times when we've seen a decrease? So we'll leave that for, let me see, 1, 2, 3, 4, 5, 6. Still got a lot of slides to cover. We'll be able to do that. Now we're going to do it Thursday for sure. I just want to think about how long it'll take. We'll figure it. We'll worry about that Thursday. So we'll end a little bit early today, just so that in the interest of time, you guys get to do with whatever time you like, whether it's sleep a little extra, go out and party on Halloween.